straight. All right, so pathophysiology, we talked a little bit about some early history and the etiology of iron deficiency. And we talked about some things that causes iron deficiency. One of the things I do want to go back and talk about just history-wise, IDA or iron deficiency used to be known as chlorosis. Chlorosis, and I wrote that up on the board. And it was called chlorosis because some of the people who had iron deficiency had a green tinge to their skin, okay? You know, chlorine is a green gas, you know, the gas chlorine, so that's the reason it's called chlorosis. So a lot of people think that, you know, they didn't really understand what was going on at the beginning because they just thought it was, you know, they knew it was iron deficiency and that kind of thing, but they didn't know what was causing it. So a lot of the people that had chlorosis at this time were puberty females who had hit puberty. And of course, when they hit puberty, that also means they're menstruating, so they were losing blood. And so, because guys never got it, they knew that men and little boys never got it during puberty. And so therefore, they just thought it was a female thing. They didn't really think about males developing IDA at that particular time. And so they called it chlorosis because of this. Not everybody took the green tinge on, but because most of them had pallor. You know what pallor is? You ever heard the term pallor? Pale. That's it. They were pale. So that was more prominent than the chlorosis. But some people did develop chlorosis. Okay? So that's a little bit more about the history. We talked about malabsorption. We talked about hemodialysis. So that leads us up to pathophysiology. So basically, what is causing diseases and the disease itself is what pathophysiology means, okay? So IDA develops in sequential stages. There are 3 stages that we're going to talk about as we go through. The reason it develops in sequential stages is because it is a negative iron balance or a negative feedback system. So basically, what happens, you begin losing more iron than you can absorb. And so therefore, you end up having it. So stage 1, and we're going to talk about each one of these in more detail. But stage 1 is basically iron depletion. Okay, so something is happening causing you to deplete your iron stores. Then second stage is iron deficient erythropoiesis. Okay. So it means we don't have iron. So zinc may take the place of iron. Remember we talked about that with the ZPP? Okay? And then the final stage is full-blown iron deficiency, anemia. Okay? You start seeing a little bit of the microcytic hypochromia in the second stage, but definitely the third stage that's characteristic. Okay? Alright, so remember, when we start talking about these, we're going to talk about the symptoms of the anemia, okay? But the disorder is iron deficiency, okay? We call it iron deficiency anemia, but the anemia, remember, is always a symptom of a disorder or the disease, okay? And in this case, it would be iron deficiency, all right? So, stage 1, iron depletion. So, essentially what happens, your iron stores are exhausted. So, if we did our iron studies, we would see decreased serum ferritin in our body. And if you did iron stains, you would probably also see a little bit decrease in the hemosiderin in those erythroblasts as you go. At this point, in stage 1, there is no anemia. The body is still compensating, still making hemoglobin, doing what it is. So at this point, the morphology is usually normal. So we have normocytic, normochromic cells, usually no problem. But RDW is increased a lot of times, okay? So what do we say that RDW tells us? When we have an increase in red cell distribution width, what does that tell us? Anisiocytosis. So that means we're seeing some cells that are small, large, normal, okay? And usually, I say large, they're usually not large. They're usually normal, or you may see a few microcytes, but you're not going to see an increase in them on the blood smear most of the time, okay? So no anemia at this point, all right? Questions about that? All right? Hospitalized patients with other disorders, okay? Ferritin levels not sensitive indicator because of iron deficiency. And RDW is not specific because they could be having some other problems that's going on. And so a lot of times there may be other things that kind of mask iron deficiency or iron depletion. And so you don't really see what's happening. Okay, stage 2. Stage 2. Okay, let me say this too. All right, IDA is insipidus. Okay, what does that mean? It is an insipidus disorder. Yes, ma'am.
It takes a while to develop.
That a girl. It takes a while to develop. So it's not like today I have normal cells. Tomorrow I'm going to have microcytic hyperchromic cells. Okay, it's going to be a gradual progression as you go through. As a matter of fact, IDA can take months, even a year or more to develop, depending on how much iron you have to start with. Okay, so like for me, if something happened and I developed iron deficiency anemia, it would probably take longer for me than you, Haley, because you're younger. Okay, so you going through menstruation and those kind of things are going to deplete your iron quicker than me. How good. Now, can I develop it? Yes, I can. There's going to be something that happens, get exposed to a toxin or whatever that causes me to develop iron deficiency anemia, but it is going to take a lot longer for me to do it than it does most of the time for young females. Okay? All right? So what happens in stage 2? In stage 2, we get iron deficient erythropoiesis. So what does that mean? That means our red blood cells don't have iron in them, right? So we're making red blood cells without iron. So there's insufficient iron to insert into the protoporphyrin ring is essentially what happens, okay? A lot of times, like we said the other day, this is where zinc comes into play, all right? So instead of iron being available like it's supposed to be, it actually is known as a competitive inhibition, okay? So if zinc's present or iron's present, they're going to compete for that spot in that protoporphyrin ring. Okay? So if you got depleted iron levels, then of course the zinc is going to be there. And here's the problem. Okay? Sometimes this can be a difficult time for a patient because if you have a patient who is in stage 1 and they're actually depleting their iron stores, and then they reach stage 2, their body tries to compensate by absorbing other metals. Okay? So like if you're living in a house that's got lead paint, guess what's going to be absorbed? Lead. Okay? If you're living somewhere that has cadmium, okay, it's going to be absorbed. Okay? Copper, any of those heavy metals, arsenic, any of those that are getting in your contact with your body's going to try to absorb them because it doesn't have iron. Okay? And so that leads to a problem with our patients. They can develop lead poisoning, they can develop cadmium poisoning, those kind of things because that competition for iron to get inserted into their heme molecule gets replaced by whatever metal's available. Luckily for us, we actually have a lot of zinc in our body. So most of the time, zinc will take the place. That's the reason we form ZPP, okay? And that ZPP is what we can use as a test for that zinc protoporphyrin instead of iron protoporphyrin, okay? All right? So another thing that occurs with people that have iron deficiency once they reach stage 2, okay? So think about stage 2. If we don't have iron because we've depleted it in stage 1, what other things do we say needs iron in our body?
The rest of our cells.
The rest of our cells. Why do they need them though? What are they making? You remember?
Chemical.
Nope. Only red cells make hemoglobin. That's what we're talking about. But the iron 3 is used for what?
Protein.
Proteins. Which particular proteins? Starts with an E. Enzymes, right? So those enzymes need iron too. There's lots of those enzymes that iron is a metallic part of the enzyme. And so if you don't have iron there, you're going to start having other problems, okay? So iron depletion in stage 1 leads to other problems in stage 2. We're looking at erythropoiesis because that's what we're talking about, hematology. But remember, there are other things that can also be a problem because iron's not there. All right? So, bone marrow sideroblasts are absent. All right? What do we say a sideroblast is? What is a sideroblast? Y'all remember? Important. Got to know what a sideroblast is. What's a sidero? What does sidero mean? What's a siderotic granule?
I'm thinking blue.
Blue. You're right. You would be going in the right path. Stain with what kind of stain would we see blue in it?
Not right state.
Not right stain.
The other one.
Not U-methyl blue, but the other one that we've talked about. No, yeah. Pappenheimer bodies on the right stain. So what would they be on the other stain? What's the other stain? Somebody said? Prussian blue. Right? Remember? So if we stained a bone marrow slide with Prussian blue, we wouldn't see sideroblasts, which is basically that hemosiderin, that stored iron that's in those erythroblasts. Okay? It won't be there. And that's a problem, because we know if we have no sideroblasts, then we know we're not producing red cells like they're supposed to be produced. So the hemoglobin's not going to be as good. So that makes sense, guys? Okay, so at this point in stage 2, we may see a few slightly microcytic cells. Okay, at stage 2, anemia and hypochromia are still not detectable. So we might see a few anisiocytosis, a few microcytes, and normal cells, but anemia has not occurred yet. Okay. All right, the CHR, which remember this is the equivalent to MCHC, but this is talking about for reticulocytes. Remember that? It is going to be low, and that's usually one of the first signs that we see that we are reaching iron deficient erythropoiesis. Okay? All right. Questions about that, guys? All right. Stage 3. Once we reach stage 3, we have full-blown IDA, iron deficiency anemia. All lab tests for iron status are abnormal at this point. Okay? You're going to see microcytic hyperchromic anemia, and then this represents advanced stage of severe iron deficiency. Once you get to that point, you're in dire need for iron. Okay? So either iron supplements will have to be given or iron transfusions will need to be given. Okay? Injections, ever how they want to do it. All right? Any question about pathophysiology? 3 stages. Know what's happening in the 3 stages. What stage you see the microcytic anemia, hypochromic anemia. Okay? All right. Stage 1. Iron depletion. Stage 2. What's stage 2? Iron deficient erythropoiesis. That sounded weird. Erythropoiesis. And then stage 3, IDA. Okay? Make sure you know what's going on in all 3 of those stages. Okay? Questions about that, guys? All right. So, like we said before, this is always clinical features. Onset is insidious, which is what we were talking about earlier. So it kind of comes on slow. It's not just today I'm normal, tomorrow I'm not. It takes a little while. So it takes months to years to develop IDA. And of course, if you've got blood loss, it's going to occur more rapidly. You guys ought to understand that. Symptoms appear as anemia develops. Okay. So one of the symptoms that is kind of weird is a variety of things that happen, but clinicia, which is concavity of your nails, so like your nails get spoon shaped, what they call spoon shaped. They have a concavity in them. So like if you were rubbing across your nails, so like your nail should be round, like that. If you rub across it, it should be round and smooth. It would be like that. And you would feel a dip in it. Okay? So if you feel a dip in your nails, it may be a sign of you having IDA. Okay? Or one of those first developing symptoms. Okay? Glossitis. I think this is like, look this up. I can't remember if this is like a smooth tongue or if this is just swelling of the tongue. I can't remember what this is, but something to do with your tongue. I think there was two things. One of them was, huh?
Swollen.
Okay, so swollen tongue then, and glossitis. Pharyngeal webs, you develop these little weird skin patches on the back of your pharynx, back in the back of your throat. Muscle dysfunction, because remember, we don't have the hemoglobin like we should because we have developed, we're not making hemoglobin like we're supposed to because we have no iron. So if you don't have that, myoglobin and hemoglobin don't work well. So myoglobin is the one that's kind of helps our muscles do what they're supposed to do. Okay, so you get some muscle dysfunction, inability to regulate your body temperature. People who are anemic are always cold, usually. They're cold all the time. All right, and then gastritis is just basically inflammation of the GI tract. Okay, stomach. Another one is pica. You guys ever heard of pica?
Eating something.
Yeah, it's unusual. How do you spell unusual? Unusual cravings. Crunchy, usually. That's the big thing. So like ice is a big one. That's usually a first sign. A lot of people that eat lots of ice, they actually have pica. Okay, they'll actually eat ice. They'll actually eat laundry detergent, dirt. They'll eat lots of starches and this kind of thing.
The lady I worked with at Walmart got fired for eating the shoe job.
Yeah. Hey, she probably had pica. No joke. I mean, it's just like an unusual craving, and it's usually crunchy stuff. But like laundry detergent. Pregnant women is the one that you have to watch a lot of times.
I wanted to eat chlorine tablets.
Yes. Pregnant women want that crunchy, and it's nothing, but they're just usually iron deficient. Yes.
My little sister has celiac disease.
Uh-huh.
Before we knew she had it, she had anemia and stuff too.
Yeah.
We didn't know that's what it was, and she would be like 2 years old, and she would get like steel dog food.
Yeah.
And she would just eat it.
Yeah. It's just the crunch, though. That's what it is. It's just a mental thing. But it's called pica. So you guys do need to know that and be aware of that. My kid ate chalk when he was little, but he ate everything. I don't really think it had anything to do with pica. I think he just ate everything. So every Sunday afternoon, or at least Monday, we could tell what colors he used in the Sunday school because his poop would be that color. Because he'd eat the crayons and crap. My oldest one. My little one didn't do that. Avery never did really put that many things in his mouth. One thing too was weird because like Trevor wouldn't take a pacifier and Avery did. Avery liked the pacifier. Trevor didn't. And so, I don't know. He ate like the beach, man. Like hands of sand when we first went to the beach. And dang, dude. Yeah. Okay. Here is pica. This phagophagia is how you pronounce this. It's called ice. That's what ice eating is actually called scientifically. Geophagia is dirt or clay. And then amylase or amylose, phagia is starch eating. But like starch eating, they'll eat lots of things though. Laundry detergent, like raw mashed potatoes, those kind of weird stuff. It would be like weird things like that. Okay? Iron deficiency in infants, this is a big deal. Remember I told you guys they go through that physiological anemia when they're growing so fast and they can't keep up with the iron that they have. So iron deficiency in infants is very, very important, and the reason it is because it actually declines their mental capabilities, okay? And kids don't do well on like tests, they don't meet milestones, those kind of things. And it can actually have a really, really long-term effect on these kids compared to kids that are non-anemic, okay? All right, questions about any of those clinical features so far? All right, one of the signs of children being iron deficiency, or infants really, irritability. They can't be consoled. They're irritable all the time. Loss of memory, and then difficulties in learning. And you'll see this a lot of times in little kids, like 2, 3-year-old kids. They just have trouble learning. And a lot of times they've proved that it is just iron deficiency. You give them some, fix the iron deficiency, it improves their learning ability. Okay? All right. So, all right. So one of the things that we see in people in everywhere in the world, and especially in America, is when you have low socioeconomic groups that don't eat properly, those are the ones that you're going to see these little ones suffering from. Okay, so one of the things that's the reason a lot of schools now serve breakfast to kids. And just about every school now has gotten breakfast for kids, and a lot of times the reason it is because lunch, is usually not enough. There are lots of kids, and I don't know if you guys realize this or not. I know we're living in America, but there's a lot of kids at schools that they eat lunch and that's it. They don't have supper at their house, and on the weekends they don't have food at all. And so it's the reason a lot of people, nonprofits and all this, are starting doing these backpacks of blessings. I don't know if y'all have heard this, or blessings in a backpack or something like that. But that's a big deal. And one of the things, the reason that is so important is because these kids, especially kindergarten, 1st, 2nd, 3rd grade, are going through that developmental stage. They need nutrition, and iron is one of the things that they really, really need to help them to succeed. And if not, they're going to fall behind. Okay, they can't help it. It's just how it is. If you don't have iron, you don't have those enzymes doing what you need. You don't have the hemoglobin to bring the oxygen to their brain, those kind of things. Okay, so do think about that as you're going along. All right, questions about that, clinical findings. All right, so let's talk about a lab. We've already talked a lot about lab stuff so far. MCV is usually low, 55 to 74. What's a normal MCV? 80 to 100. Okay. MCH and MCHC. MCHC, this is going to be the one that we look at most of the time. Of course, we're going to get this, but we look at this one. Anything less than what?
16.
Nope. What's a normal MCHC? That's the high part. What's the low part? 32. 32 to 36 is a normal. So anything below 32, you're going to see hypochromia. So you're going to see lots of central pallor, no red. Okay? So those are the things we're looking for. Then the MCV, of course, tells us we have microcytic. So microcytosis, which I've already told you guys, anytime you see osis on the end of a word, it's an increase in. Okay? So that means increase. Okay? There's another term that we're going to learn eventually, might as well learn it today, is penia. Okay? Anytime you see penia as a suffix on the end of a word, it means a decrease in. Okay? So like leukopenia, erythropenia, which we don't ever call erythropenia, we call it anemia. Okay? Thrombocytopenia, those kind of things. Those are low numbers of those particular cells. Whereas when we see osis, we see an increase. Okay? So microcytosis is an increase. All right? And then an increase in RDW, and then these are usually the first morphological signs that you see. And then most frequent poikilocytoses that are associated with anemias are target cells erythrocytes, and the keratocytes, which are teardrop cells. Okay? So those are what you're going to see pretty routinely on iron deficiency anemia. All right, questions about that, guys? All right, so the peripheral blood, what do you see? Relative or absolute retic count, maybe normal or slightly increased, but your RPI, remember we talked about the RPI, is less than 2. CHR, which is dealing with the chromatin or the color of the retic, so how much hemoglobin is in them. This is an early indicator of iron-restricted erythropoiesis that we talked about. So this is what's going to happen in that second stage. You're going to start seeing some of this stuff in the second stage of iron deficiency. WBC count normal to increase. The reason it would be increased is just because of just kind of weird stuff happening in your body. Kind of triggers the white cells to kind of activate. Okay, platelet count normal can be increased or decreased, so we don't ever even look at it. But thrombocytosis frequently accompanies IDA, and a lot of it's because of the liver and those kind of things kind of get disrupted as we go. Okay. All right, questions about that? The big thing, guys, is remember microcytic hypochromia. That's the thing about IDA. You need to know microcytic hypochromia. Okay? And you'll need to correlate what MCV is, MCH, and MCHC. Those are the important things right there. Okay? As you go. All right? So this is typical blood smear of a IDA. Okay? So you can see the washed out cells. Okay? See how washed out they are? Okay? Lots of initios of different sizes as you go through. Some poikilocytosis, you're seeing some echinocytes, mesocytes. There's weird stuff happening. Okay, elliptocyte, and I don't see a target, but throw one in there somewhere. I guess I could get by without there being a target. Okay, but this is typical for iron deficiency. Okay, kind of look at it. Questions about that, guys? All right. Okay. So iron studies, of course, serum iron level is going to be decreased, usually less than 30 micrograms per deciliter. CIBC is going to be increased because there's no iron to bind to the transferrin. Okay, so transferrin saturation is decreased, usually less than 16%. Talked a little bit about that the other day. Serum ferritin levels decrease in all stages of IDA. This is one of your first indicators of developing IDA. So a lot of times they'll do the CBC, but the CBC will be normal, so then they'll move to the iron studies in the serum, the chemistries for this. And so serum ferritin levels of less than 12 micrograms per deciliter, this lets us know that you have depleted all your iron stores. Okay, you have to remember that iron is diurnal. Okay, diurnal variation. Remember what we said diurnal variation meant? What does that mean? Different at 2 different times of the day. 2 times. Okay, so highest levels in the AM. And by the PM, so they'd do a 6 in the morning, 6 at night. The one in the morning will be higher than the one at 6 p.m. Okay? All right? STFR, serum transferrin levels, is what this is. Useful in differentiating IDA from ACD, which is anemia of chronic disease. Okay? Remember, we're going to talk about that in just a minute. Level in IDA is high and normal in ACD. All right, and then there's some calculations there, and I don't really care if you know that, okay? So all that's calculated for you. Another test you can do, of course, is the erythrocyte protoporphyrin studies, and the big one is the ZPP. And this one correlates inversely with ferritin, okay? Correlates inversely with ferritin. And the reason is because zinc's taking the place of iron, so if it's increased, ferritin levels are decreased. questions, guys, about that? All right. So, basically, the ZPP test is what it's talking about here. Detects iron depletion before anemia develops. So this would be one that you would do in stage 1 and stage 2 if you were suspecting iron deficiency. So you would do the ZPP. So it's a good screening tool for early stages of IDA, but it's hard to differentiate IDA from thalassemia using this, okay? And they actually found that, and we're going to talk about this in just a minute, the ZPP can also be used in lead poisoning tests, but it's not a good screening tool because of thalassemia and IDA, okay? And now don't take this wrong, I'm just throwing this out there and telling you true facts. A lot of times, low socioeconomic people who live in like project housing and those kind of things, they tend to be prone to lead poisoning, but they're also prone to IDA because of the malnutrition. Does that make sense to you? So you wouldn't want to test for lead poisoning using the same test that's affected by IDA. Because if they've got IDA and thalassemia, the test is also going to be elevated in it. And so it wouldn't be a good screening tool for lead poisoning. We're going to talk about that in just a second, but throwing that out there, okay? So the ZPP and iron deficiency 3 to 4 times higher than in thalassemia. We hadn't talked about thalassemia, but thalassemia, especially alpha thalassemia. So remember we talked about which one's got the alpha genes on it? Chromosome 16. How many alpha genes do we have? We have 4, right? We have 1 and 2 on both genes. So thalassemia, alpha thalassemia, that's the problem, okay? One of these is deleted, or 2 of these are deleted, or 3 of these that are deleted. So you're not making alpha genes. You may have enough to have 1, and it'll make alpha, but it's just not good enough to make it, okay? So of course they're going to develop anemia, and it's going to look very, very similar to iron deficiency anemia, but it's really not, okay? So that's one of the things it's talking about here, the ZPP in iron deficiency, 3 to 4 times higher than in thalassemia. So you can actually use it to help you to justify thalassemia, which of course you wouldn't because you would do genetic testing, okay? We'd look at those genes, all right? So more efficient than serum iron or ferritin in screening IDA in hospitalized patients. So the ZPP can be used. It's just expensive and nobody really uses it that much, okay? All right, so bone marrow. So we do look at the bone marrow a lot of times in IDA. I'm going to be rude. I'm going to tell you a story. I don't really care. I hope none of you guys are not kin to him. I ain't going to say his name so y'all never know. So I had this kid working when I was, of course, I was already, older. Been in the lab for several years. But we had this guy who was a phlebotomist. He come in and he had this genetic disorder where he didn't have like pigment in certain spots of his face. So like one of his eyelids or eyebrows was like white and the other one wasn't. So like I called him white eye. I know that was wrong. Kara's like rolling her eyes at me. You're so rude. Yes, I know. I didn't call him back to his face. I was nice to that point. Just behind his back, I called him white eye. So this kid was weird. I don't know if he had like a mental disorder or what, but he started getting sick and like anemic. And he's got, and he wasn't a vegetarian. You know what I'm saying? So he ended up becoming anemic and like becoming so bad anemic that they actually put the kid in the hospital and did a bone marrow aspiration on him to see what was going on, to see if his bone marrow just wasn't producing iron or, he wasn't producing the cells or whatever. So it turned out this kid was drawing his own blood. Like we caught him one night, drawing his own blood and just throwing it away. So he was doing it for attention is what it was. But my point is, iron deficiency anemia can get so bad that you start having to do bone marrow studies to make sure that that's not the problem, And so therefore, of course, he got in trouble and ended up getting fired. And while he was in the hospital, he was actually in an MLT program at Jeff State, and he missed the final because of being sick. And so instead of just saying, you know, I'm in the hospital getting his doctor to write an excuse, he just made up one. Like created an excuse with a doctor's name and all this other stuff, and a hospital and so like. I said he wasn't normal. He was drawing blood on himself. Kim, we ain't talking about stupid. We're not talking about normal people anymore. Yeah, stupid. So one day after they fired him and everything, my boss came in and she was like cleaning out the lab and cleaning up stuff. You know what an acid cabinet is, right? Metal cabinets you put acids and bases in. So she like opened the acid cabinet and started putting crap on the shelves, and I was like, "What are you doing?" And she said, "Well, I'm putting this stuff in the thing." I said, "Stop." She said, "Why?" And I said, "Because that's my hiding place when White Eye comes in and shoots the lab up." She's like, "Joseph, you're so mean." I said, "Well, I know it is because I done crawled in there to make sure I could fit." She was like, "Joseph, you're just crazy." And I was like, "Well, not as crazy as him. So, you know, just don't be messing up my hiding space." Yeah. So she's like, so bone marrow. So bone marrow testing, of course, is necessary. So mild to moderate erythroid hyperplasia. Okay, so hyperplasia means what? Increase. Hyper does. What's plasia mean? That actually means increase in the number of cells, which is kind of weird, right? Because we would think if we have iron deficiency, we wouldn't be making cells. But why are we making cells? Huh?
That's what it does all day.
That's what it does all day. No, it doesn't do it all day. It does it as it's needed. So why would people who have iron deficiency anemia have hyperplasia or increased production of red cells in their bone marrow?
To try to get what they need.
To try to compensate. That's exactly right. So like we talked a little bit about like if I sent you guys to Denver today and y'all stayed in Denver tomorrow morning, okay, and you've been there for 24 hours and I did a bone marrow aspiration, every one of you would have hyperplasia. Because y'all's little happy butts used to being in Alabama with a little bit low compared to Denver. I mean, we've got some elevation, but not that much, not like mile high, you know, elevation. So your body would go into shock a little bit, and it would say, "Oh crap, we can't breathe. There's not enough oxygen in our body to make us function." And so it would kick up production of your red blood cells. So this is what happens when people have IDA. Well, if you have IDA, yeah, you may have low hemoglobin and low red cell count, but if we pulled bone marrow out, you would see an increase in the production of the RBCs, okay? And it would actually start pushing them out more, okay? So remember, and I guess I should have told you this earlier, it should have been on that slide, but it wasn't. So on that peripheral smear slide, what's another thing that's commonly seen in IDA? Microcytes and hypochromia, but what's another cell that shouldn't be there, shows up sometimes? So I got all these guys in my bone marrow. What's eventually going to happen? They're going to get kicked out, aren't they? Okay? So metaroots or is it orthochromic normoblast? I think. I can't remember. Orthochromic normoblast, I think is it. So the metarootocyte, the one right before the nucleus gets kicked out to become a reticulocyte, called the metaroot, a lot of times they'll get kicked out because how much hemoglobin do they have in it? 80%, right? So they should have at least about 80%. So kind of like kicking the 15-year-old out of the house and said, "Look, you got to work to help pay the bills." Okay? They're probably not going to do a good job, but they can at least bring home a couple of dollars. You know what I mean? Does that make sense? And that's kind of how it works. And so you'll see those metaroots get kicked out because of this increase in hyperplasia in the bone marrow. Okay?
What smear was this?
Bone marrow. Bone marrow. It'd be right
I
stain.
wrote down pH.
I don't know why you wrote down pH.
It wasn't what?
We ain't talked about anything about pH yet. No, I hadn't mentioned that one. I said peripheral blood. Well,
Oh, okay.
that's probably what it is. I said that you'll see some metarubicytes or orthochromic normoblasts in the peripheral blood a lot of times.
Oh.
People that have really, really severe iron deficiency anemia will have nucleated red cells, what we call nucleated red cells on their blood smear. Okay? And that can be normal. Well, it's not normal, but you see it. Okay? It's a normal thing to see in those patients. Okay? So increased bone marrow activity without corresponding increase in peripheral blood retics. Okay? So what it means, basically, you have kind of incomplete erythropoiesis, ineffective erythropoiesis. So they get to the rubicyte stage, the metarube, but then they don't go any further. They just kind of die in the bone marrow because they don't have enough hemoglobin and those kind of things. Okay? All right. Erythroblasts poorly hemoglobinized. So your iron stores, there's absent hemosiderin in the macrophages. Sideroblasts are markedly reduced or absent. And this is one of the things that we talked about a little bit a while ago. Okay? So this kind of shows you a little chart. So here's our threshold of iron. Okay? So once we reach this spot, then we're going to decrease really, really rapidly. So normal, you're starting to get some storage iron depletion. So then you start seeing a decrease in your erythropoiesis until eventually you get down to true IDA as you go. Okay? So that's one of the things you need to look at there.
How long does that take?
Months or years. Remember? We just talked
From
about that.
stage 2 to stage 2?
But it can still take a few months, yeah. Mm-hmm. Yeah. Just depends on how much you got, you know. Like I said, I would probably take me longer to develop IDA than it does you. Okay? All right. Treatment. Treatment, the most important thing to treat therapy is to treat underlying disorder. So whatever's causing it. Remember, anemia is a symptom. It is not a disorder. Okay? It is a symptom of a disorder. So you fix the disorder, you fix the anemia. So that's what we need to do. So that can be lots of things. It can be, you know, depending on what's causing it. If they're being exposed to lead, they're being exposed to some other toxin, whatever it is, remove the toxin. Does that make sense? If they're not eating enough, provide them with the food. That kind of thing. All right? So treatment of your underlying disorder is the best therapy for IDA. Okay? And then, of course, you can start giving iron supplements and those kind of things. Okay? So administer iron, oral administration, or parenteral, which is basically injection. This means injection. So it can be IV or shots, injections. Okay? Questions? So, first thing you're going to do is you're going to observe the response of therapy. One of the big things is reticulocyte count. Okay? Reticulocyte response begins about the 3rd day of treatment. So you ought to start seeing an increase in your reticulocytes. Okay? And that'd be that the CHR should begin to increase. And then hemoglobin should return to normal between 6 and 10 weeks of therapy. Okay? Questions about IDA. All right? Now listen to me. There will probably be 2 or 3 questions on your boards about IDA. And I know y'all are thinking, holy crap. I'm just telling you. There'll probably be 2 or 3 questions out of the 25 that you're going to get, 25%. Okay? So IDA, you think 2 or 3 is not that important, they are. All right? So IDA is very important to make sure you're familiar with. Okay? So no IDA. Okay? Any questions about this? All right, so let's talk about the next type of anemia. Anemia of chronic disease, okay? Chronic of course, means what?
Ongoing.
Acute, chronic. What's acute?
Sudden.
Short term, sudden, immediate, right? Chronic is long term, okay? So this is things that can happen in a long time. Also known as anemia of inflammation or infection, okay? So sometimes things that we get a really, really severe infection, we get some kind of inflammation problem going on, it leads to a form of anemia, okay? It's not IDA, but it is a form of anemia, okay? So, what do we see ACD in? Chronic infections, chronic inflammatory disorders, okay? A lot of times people who have autoimmune disorders, okay? Lupus is a big one, okay? You guys know what lupus is? So lupus is a big one. A lot of times people who have lupus have lots of anemia problems, okay? Trauma, organ failure, and then neoplastic disorders. When we talk about organ failure, what would be one organ that would be really concerned that would cause lots of anemia? Kidney. That's right. Anytime you have kidney failure or kidney problems, it's going to lead to an anemia at some point, because remember, what does our kidneys produce that we need? Come on, guys, that's basic. This is basic at this point. What is so important for us to make red cells? Say it loud. EPO. And guess where EPO is created? Erythropoietin is made in your kidneys. Okay? So anytime you see kidney failure patients, most of the time they're going to have a form of anemia. If they don't have anemia, it's usually because they've given them synthetic EPO. Okay? Recombinant EPO. Okay? So there's some different things that you guys need to kind of be familiar with. This is lupus, systemic lupus erythematosus, I guess is how it's pronounced. We just call it lupus, or SLE, most of the time. Rheumatic fever. Rheumatic fever, I think, is caused by strep. I think that's a thing when you allow strep infections to go for a while, you can develop what's called rheumatic fever because of that. Okay? Rheumatoid arthritis, sterile abscesses, those kind of things. All these kind of things can lead to ACD. Other things, malignant diseases. Why would malignant diseases cause us a problem? What does malignant mean? Spreads, right? So a lot of times malignant diseases that we think about are usually like certain leukemias, okay? Those are the ones that usually cause us to have anemia. And the reason it does is because our bone marrow loses its mind and starts making one particular white cell. And so it stops making any kind of red cells or platelets even. And so you start seeing patients that have huge white counts, but they're anemic because of this. Okay? Alcoholic liver disease. Okay? Alcoholics can have some weird stuff happening to them. Okay? And then all these other things, you guys just need to kind of know a few of those. All right? Questions about those, guys? All right, so characterized by low iron, serum iron levels, but their iron stores are usually normal. So like their ferritin levels and transferrin, TIBC, all that stuff is usually pretty normal. It's just they're usually a little bit low in iron, okay? Does not relate to nutritional deficiency. Most anemias other than IDA have this. Counts for anemia in 1/3 of all anemic hospitalized patients. Okay, so people who are in the hospital a really long time can develop anemia, and it's usually considered a chronic anemia. All right. So things of causes ACD, multifactorial, so mostly linked to inflammatory cytokines. So you remember those acute, what do we call them? Acute phase reactants. We were talking about the other day. I made you the little protein electrophoresis chart. We talked about the alpha 1, alpha 2, betas, and the gammas. Alpha 1, alpha 2, and beta are really your acute phase reactants. And so that causes a lot of problems with some of the things that happen in our blood. So hypoferritemia means that decrease in ferritin, so decrease in transferritin, serum ferritin. Serum ferritin goes up, not ferritin in the bone marrow, but serum ferritin, and then increase iron in bone marrow macrophages as we go. Okay. Basically what happens, you have a block in the mobilization of iron from the macrophages for like recycling to bone marrow erythroblast. So this gets blocked. It's usually by interleukin 6. So block mediated by increased hepcidin. Remember what hepcidin does?
It's a regulator.
It's a regulator of our iron absorption, right? Okay. So in response to interleukin 6, interleukin 6 is another type of cytokine, and then there's other inflammatory cytokines that cause us a problem. All right. So decreased EPO production is another thing that could cause ACD. We talked about that a while ago. So those are just some things that you need to know. These 4 mechanisms are some of the things that you guys need to be familiar with. Okay, I'm not really going to spend that much time on this because it's really not as important as like IDA. Okay, so we're going to go through this pretty quick. Remember, it's just like any other anemia, it is associated with underlying disorders. It's rather severe. Most of the time we can correct it when we correct whatever's going on, give them antibiotics to fix the infection, those kind of things, and it pretty much just fixes itself. Okay. It's a little harder to fix sometimes in people who are alcoholics, people who have alcoholic liver disease and those kind of things. But most of the other stuff, it's usually pretty easily fixed. Okay. So what do you look for? Mild anemia, hemoglobin less than 9, hematocrit usually not less than 25. So 10 to 11 is usually what you're going to see. RBCs are usually normocytic. There's really no reason for them to become microcytes unless it continues for a long time. And then eventually they will get a little smaller. RPI is usually less than 2, and then your WBC and platelets are usually normal. So you see the very, very mild anemia in this. You just see it for a while. Okay? So remember, that's why we're calling it chronic. Okay? Of this. All right? So there's a pretty good smear of this. What's this? It's a Howell Jolly body. Somebody was asking me the other day what a Howell Jolly body looks like. That's a Howell Jolly body. Okay? One. There's usually just one in the red cell as you go. Okay? Some of this other is just crap, like that kind of stuff you're seeing. Those are platelets, of course. But look at the cells. Red cells are normal. There's no problem with the red cells. They're not hypochromic. They're normocytic. So usually that's what you see with ACD. Okay. Iron studies, decrease serum iron, decrease in normal TIBC, and then normal to low transferrin saturation as you go. Okay. You can look at that. Normal to increased serum ferritin is what distinguishes it from IDA. It's usually right the opposite with serum ferritin. You also see an increase in those acute phase reactants. So if you did a a protein electrophoresis, you would see some abnormalities in those alpha 1, alpha 2, and beta bands that we talked about. Okay. Also, those transferrin receptors, remember we talked about those earlier, is usually normal for ACD and then increased in IDA, and then the ZPP can also be increased. Okay? ME ratio. Have we talked about ME ratio yet? Let's talk about ME ratio. ME ratio. ME ratio should be about 4 to 1. Okay, ME stands for myeloid versus erythroid. Okay. Okay.
What's a myeloid again?
Huh?
What's a myeloid again?
White cell. Myeloid. So myeloid is monocytes, neutrophils, basophils, eosinophils. Those are all myeloid cells. Well, remember all that stuff we talked about? You know, you got the common myeloid progenitor, the common lymphoid progenitor. The myeloid itself could be red cells, white cells, platelets, all that. But in this case, we're talking about the myeloid white blood cells. So basos, eos, neutrophils, monocytes. Okay. As we're talking about bone marrow. Okay. Poor hemoglobin production in the erythroblast, so you're going to see a decrease in that. Sideroblast is less than 30%, so you're going to see a decrease in the hemosiderin in the erythroid cells. But in the macrophages, you're going to see an increase in hemosiderin. So when you did your iron studies, your Prussian blue, the macrophages would have lots of hemosiderin in them. They'd have lots of iron in them. Whereas the blast, the sideroblast, would be decreased. Okay? This one right here is what aids in differentiating IDA. So in IDA, macrophages would be decreased. The hemosiderin would be decreased in the macrophages. Okay? Questions about that, guys? All right, let's move on. This is what an iron stain looks like. This is a bone marrow. So everywhere you see blue, those are iron stains. Okay? So you see lots of iron. So here's some more iron here and here. Okay? That's what you would see on a bone marrow with a Prussian blue. Okay? All right, therapy, of course. Usually when you treat whatever the underlying disease is, transfusion is usually not warranted because they usually don't have any kind of, once you fix the problem, everything corrects itself pretty quickly. Okay? All right, questions about that? IDA, ACD. Know a little bit about each one of them, especially the IDA. Okay? All right, so anemia is associated with abnormal heme synthesis. These are going to be important to us also. Okay? So, two things we're going to talk about. Well, three actually. We're going to talk about sideroblastic anemia. We're going to talk about lead poisoning, known as plumbism. And then we're going to talk about porphyrias. Porphyria. Okay? I missed that word. I missed the word. Porphyrias. Okay? These are all problems with heme production. Okay? That leads to anemia. Okay? So we've talked about iron. Iron's very specific. Most of these other words, we're either going to talk about enzymes that are missing. Okay? Like ferrochelatase, the protoporphyrinogen enzymes, and those kind of things. Okay? So, defects in enzymes of the heme. Okay? So, these are different than IDA. Even though IDA leads to a decrease in hemoglobin, it's because we're missing iron. Right? But in this case, we're missing an enzyme. Okay? One of the big enzymes that we're going to talk about is ALAS2, which is what? What? Plumbism. 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 That's the science word for lead poisoning.
You missed Kayla's grading.
Say it again.
For ALS, we know the glutamic acid synthesis.
There you go. That's it. That's exactly right. So where does that occur? Where is this necessary? Mitochondria. And what part?
The erythroblast.
But what part of this? Where is this happening at? Where is this necessary to occur? What did we say was the first two components of heme production?
Glycine and acetyl-CoA.
That's it. Glycine and acetyl-CoA form what? Aminolevulinic acid, right? And then aminolevulinic acid gets exposed to this particular enzyme to go down to the next production of the, it's like the uroporphyrinogen and then coprotoporphyrinogen, those kind of things, okay? So that's where we're at, all right? So this, of course, is happening in the mitochondria and the cytoplasm of the erythroblast, okay? So you don't have the enzymes, you can't make heme, okay? You can't make the production of heme. So if you can't make the production of heme, you can't make hemoglobin, which is usually what our problem is. So iron incorporation into the protoporphyrin is usually blocked in these. So you have increased iron stores. So one of the questions that I may ask you on a quiz or on, or a practical, I would put like a picture of Pappenheimer bodies on a right stain. All right, and I would say, okay, your patient has normal iron levels, but they have anemia. What would be the problem? Okay, and then you would let me know something about sideroblastic anemia or porphyria, depending on whatever else I have. Because a lot of times they will have increased iron stores. Their iron will actually be stored because iron is just hanging out because it can't be introduced into the hemoglobin molecule. So they develop like an IDA, but it has nothing to do with iron levels. Okay, does that make sense? So you can have anemia, and it can even look like microcytic hyperchromic anemia, but it's not got anything to do with your iron level. Okay, in this case, it is an enzyme problem. All right. So serum ferritin levels greater than 250. Now this one right here, we're going to talk about it in this chapter, but later on we're going to talk about another one. It's called refractory iron deficiency or siderotic iron deficiency anemia. It's called RARES. We'll talk about it in just a minute. It has to do with ringed sideroblasts. Did I use that? Have I used that term yet? Okay, ringed sideroblast. Okay, ringed sideroblasts basically are just erythroblasts that have iron in them, but it's around the edge instead of being like scattered inside it. And so they refer to them as ringed sideroblasts. There's some of the people that develop certain leukemias, and they develop also rares to go with the leukemia. And we'll talk more about that in the leukemia chapter. Okay? All right, so sideroblastic anemias, this results in a mutation that affects the first enzymatic step, formation of ALA. Okay? What is it? It's delta 5 aminolinoleic acid. Is that right? As you go. A couple of forms, hereditary, congenital, and acquired. Okay? Hereditary is different than congenital. I don't know if you guys know that or not, but these are different. Hereditary, you may inherit it, but you may not really show any symptoms until you get a little older. Okay? Congenital is inherited, but you start seeing it at birth. Does that make sense? And then you have what's called acquired, and that's usually like the one we're going to talk about with the leukemias and stuff. Okay? And also, like lead poisoning would also be a form of acquired. Okay? Or any kind of toxic or drugs. There are some drugs that you can take that can also lead to sideroblastic anemias. Okay? So all types, so hereditary, congenital, or acquired, are all characterized by increase in total body iron, ring sideroblasts in the bone marrow. So this is what I was talking about before. So instead of like you having a, like a, well, that's too big. To be correct. Oh, God, I'm old. Okay. So if we were looking at, got our chromatin and our domine and all that of our erythroblast, okay? So a lot of times you may just see like one or two little patches of iron if you stain it. Does that make sense? But people that have ring sideroblast, they'll have lots of them, and they'll be right on the edge of the cytoplasm as you go. Okay? So it goes around it. So it's ringed around it. So they're referred to as ringed sideroblast. Okay? And then you have a hypochromic anemia with these. Okay? Because we don't have any hemoglobin. Okay? All right. Hereditary. Most common is due to a defective X-linked recessive gene. So who's more affected by these? Men. Okay? Listen, anytime in science you see defective X-linked or X chromosome, it is always males who are going to be affected by this. Okay? Because we only got that one X. You girls, you got two of them. So usually you can compensate. Y'all are carriers, but you can compensate because you do have a normal X chromosome. But on us guys, because we have XY, if it is an X-related problem, then we're screwed. Okay? We're going to talk about lots of those later on. Well, crap, my brain just went blank. Color blindness, hemophilia, A and B, both of those are all on the X chromosome. So males tend to be affected where females don't for those particular disorders. Okay? Carriers are usually females, rarely have anemia. They may have some dimorphic. What's dimorphic mean?
Two types.
Two different forms. So they may have some microcytes and some normocytes, those kind of things, of normal and abnormal cells. But males are the ones who are usually affected, and they'll see the signs of sideroblastic anemia that we just talked about. Okay? Acquired form. So we didn't talk about congenital because it's the same thing. I told you the difference between heredity and congenital just now. More common than the hereditary forms. Idiopathic. Idiopathic means it's unknown what causes it. Okay? There are lots of things that can cause it. We have rares. I'm going to go ahead and introduce you to it, but we will talk more about this when we get into the leukemias. It's called rares. Refractory anemia with ringed sideroblasts. Okay? Rares. In rares, either sex can be affected because it's acquired. And lots of these acquired ones can be male or female. And then usually it may terminate in acute leukemias. Okay? So what that means is rares can actually trigger a person to have an acute leukemia also. Okay? But you do see it sometimes in leukemia patients. They'll develop rares as they go. But it can also be vice versa. Okay? And we'll talk more about that later on when we're talking about leukemias. Okay? But just be familiar, there is a rare one, refractory anemia with ringed sideroblast. Okay? Secondary to underlying disease or toxin. This can be drugs, toxin interference, all these different things with those enzymes. Okay? So here's a little chart. You guys need to be familiar with that chart as you go. Okay? Pathophysiology of the siderotic anemias, defects of interference interference with enzymes regulating your heme synthesis. Okay. Ringed sideroblast, that's what we talked about before. It's formed from accumulation of non-ferritin iron in the mitochondria. They usually have a circle around the erythroblast nucleus, and they can have it also around the cytoplasm. Prussian blue reveals the ringed sideroblast as you go. Okay. Hereditary sideroblastic anemia. This is the most common enzyme effect, and this one is the ELAS. Okay. There are two forms of ELAS. Okay. ELAS1 is usually non-erythroid. It's produced in the liver. So I'm not going to talk about it. It is there. It helps with lots of those other things. It's not heme related though. Okay? But the ELAS2 is erythroid. And this is the one that bothers us, or we have a problem that leads to the sideroblastic anemia. Okay? This enzyme is the first rate-limiting enzyme in the process of making heme. So if you don't have that enzyme present or it's messed up, then that's what leads to decreased hemoglobin. Okay? Sex-linked sideroblastic anemia due to that abnormal ELAS2. What do you see in the bone marrow? You see erythroid hyperplasia, ineffective erythropoiesis, so we never reach the reticulocyte stage. So you see an increase in erythroblast, but you don't see an increase in normal mature red cells as you go. Okay? Increase in iron absorption in the gut, which leads to overload of iron. And this, of course, leads to complications in cardiac failure or diabetes, these people. Okay? We talked about refractory anemia with ring sideroblast. We're not going to spend that much time on it. RARES is usually acquired stem cell disorder. We'll talk about myelodysplastic syndromes when we start talking about the leukemias. So I don't really just kind of be familiar with it, but I don't really care that you know it. Okay. Most common toxins that leads to acquired sideroblastic anemia are lead and alcohol. People who are alcoholics have a high rate of making or developing acquired sideroblastic anemia, okay, as they go. Lead poisoning, plumbism. It's usually in children. This is usually where we see it the most, and it's usually ingestion of lead paint, okay. Adults, it's usually a result from inhalation of lead compounds in some industrial process, okay. So kids chew on the windowsills of their low-income housing. That's usually where they get it. I know that sounds ugly, but that's just the truth. During the 60s, when they started making all the housing projects because of the civil rights movement and all those things, the civil rights laws and different things, they started providing housing for low socioeconomic people. All paint had lead in it. That was just how paint was made. But then when we discovered that lead was a problem, then of course they went in and slapped new paint on, but didn't take the lead paint off. So you got little kids that chew on the windowsills and everything else that's got paint. They get down to the lead layer, the paint layer that's got the lead, and so it ends up getting in their system, and they get lead poisoning from it. Okay. And then, of course, adults, we tend not to chew on paint, but we do work in industries. And so that's usually where we end up getting it. Okay? So, lead poisoning, marked abnormal heme synthesis, leads to accumulation, or lead accumulates in the mitochondria, so then it competes and it inhibits cellular enzymes in heme synthesis. Okay? You can read a little bit in your book about that, and it'll tell you which enzymes it interferes with. Okay, so basically these delta amino levulinic acid dehydrase is the one that it messes with, and also it messes with ferrochelatase. And remember what's ferrochelatase do? It's the one that transfers iron into the heme molecule, into that protoporphyrin 9 ring. Okay. So iron's available, but because ferrochelatase is being disrupted by lead, then it doesn't insert the iron. Okay? So how do we diagnose it? Urine excretion for delta amino levulinic acid is what we look for. So you see increases in ALA in the urine, and then you can also do a ZPP on them. Okay? So it's also increased too, but it's not a good screening tool. Okay? Questions? All right. Alcoholism. Listen to me. I'm going to tell y'all a little secret. Okay? Nobody had never been an alcoholic if they'd never take their first drink. So just don't. Just don't drink. Okay? I pitch a fit a lot of times. People just don't realize it. We know there's an alcohol gene. We know it without a doubt. Okay? So if your papa's an alcoholic, your daddy's alcoholic, your mama's alcoholic, your aunt and uncles are all alcoholics, guess what? You've got a huge risk of becoming an alcoholic. And every alcoholic in this world never wanted to be an alcoholic. I guarantee it. Okay? So trust me, alcohol hurts you. Okay? I know y'all are all adults, but crap, listen to me. Okay? Alcohol causes lots of problems, not just physically and emotionally and everything else can do to families and that kind of thing, but physically causes lots of problems in our body. So it's best to just stay away from it. Okay? So you guys can read through this and see why alcohol causes problems. All right? Questions about this? Okay? All right, this kind of shows where things can get messed up, and it is also an algorithm to help us diagnose different anemias in alcoholics, things you can look for. So here's the weird thing about it. Alcoholism can cause a anemia that's very close to iron deficiency, but it also, we're going to talk about one when we start talking about megaloblastic anemias that have large red cells, okay? And it looks very similar to like vitamin B12 folate deficiency, okay? So it's a little weird in that case, okay? All right, talked about this already, so let's move on. Let's get, one thing to do, you need to remember Pappenheimer bodies. We talked about Pappenheimer bodies. They're iron aggregations that you can see on a right stain, okay? Those are notoriously seen in people who have sideroblastic anemias, okay, as we go. All right, questions about that, guys? All right, so you guys can read through this. You can look at this, lots of poikilocytosis. This is the Pappenheimer bodies. You can see how they look different than Hal-Jolly bodies. As you go, there's usually multiple in each one, so that's always an indicator that it's probably Pappenheimer bodies, okay? All right, basophilic stippling. They showed you this picture. This is basically lead poisoning is where you do see this, okay? Can also see it in sideroblastic anemia, all right? Basophilic stippling, your cell is dead. It is a dead cell, okay? So if you see somebody's got lots of basophilic stippling, they having problems because most of their red cells are dead. Does that make sense? Okay? So they don't do their job. All right, so kind of look at those lab results. We talked about haptoglobin already. I mentioned haptoglobin to you guys already. What's haptoglobin do? I know we've mentioned it because we've talked about heme breakdown. What's haptoglobin do? Binds what? Free hemoglobin. So like in people who have like, what we talked about big was like people who have hemolytic anemias, when they release the hemoglobin out of the red cell, haptoglobin gets it. That's the reason you're also seeing a decrease in haptoglobin, because people who have sideroblastic anemia, their red cells, the longevity is not the same. Their red cells may not live 120 days. They may only live 18 days, or 20 days, or 50 days, okay? So their cells are going to die quicker, so you're going to see a decrease in haptoglobin because you see more free hemoglobin in these guys, okay? All right, so you can also see increase in bilirubin, which is because of the hemoglobin. We haven't talked about lactate dehydrogenase. It's an enzyme that's in our lots of our cells, especially red blood cells. So if you see an increase in LD, usually, or I call it LDH, everybody else calls it LD. But anyway, you see an increase in it lets you know you're either having some cell destruction other places or your red cells are being hemolyzed. And so that's usually what you're seeing in the iron sideroblastic anemias. Okay, just kind of read through this and you can kind of see what we're talking about. Those are ring sideroblasts, what I was talking about earlier. They are around the nucleus, but because the cytoplasm nucleus is so close to each other, it looks like it's around the cytoplasm also. Okay, all right. Trying to get to therapy, peroxidine therapy, iron overload reduced by phlebotomy, and then folic acid levels also for megaloblastic features, okay? Hemochromatosis, all right? We'll talk about hemochromatosis real quick. Hemochromatosis is a form of iron overload. So essentially what happens is people stop being able to use iron and they lose the ability to recognize that I don't need to absorb iron. And so their body absorbs every bit of the iron they take in. And if you're absorbing iron, your body thinks, well, I got to do something with it. So it either starts depositing in the tissues and they develop this bronze-looking skin tone, or they make red blood cells. And when they make red blood cells, their hematocrit goes up high, like 60, 65%, okay? And normal should not ever be above about 50, okay, as you go, all right? So that's hemochromatosis, iron overload, all right? You have excess iron deposits, so therefore you start making red blood cells. Can be classified as hereditary or secondary. Okay, secondary, of course, is like from drugs and these kind of things. Hereditary is actually an abnormality, okay, in a gene. okay? So in these people, basically what it is, they basically have uncontrolled release of iron from the macrophages. So they make plasma. They continue to make red blood cells. The enterocytes don't know to not absorb iron, and so they do absorb all the iron that they can, okay? So they get excess iron deposits in the hepatocytes, in the parenchymal tissue, these kind of things, all right? So genetic disorder, 1 in about 200 to 250 people. 1 in 10 Caucasians. This is one of the things you don't really see in like African Americans or Asians. This is a white disorder, okay? They're usually the ones that you're going to see this in. I don't know that I've ever seen an African American have hemochromatosis. 5 genes have been implicated since we know that the Human Genome Project, the HAMP gene is the one that helps produce hepcidin. And so essentially, the more hepcidin you produce, the more iron you're going to absorb, all right, as you go, okay? So just kind of be familiar with this as you go. Now, we're not going to spend a lot of time on this because you guys can read through this on your own, okay? Lots of things you can do for hemochromatosis. The big one is phlebotomies. Therapeutic phlebotomies is the #1 treatment for these. Once you do the therapeutic phlebotomies, if that doesn't work, they can actually do drugs. Chelation therapy is what it's called. And it's drugs that basically go in and chelate or grab iron in their body. And then they take it out through your urine or your poop, either one. Okay? All right? Porphyrias. Okay? Spend a little time on porphyrias. What time is it? 11:30? All right, so we got about 10, 15 more minutes, which is good. All right, so inherited disorders characterized by block in porphyrin synthesis, okay? So this is happening in the cytoplasm, okay? Right before it goes from the cytoplasm back into the mitochondria, okay? So abnormal porphyrin metabolism is due to defect in one or more enzymes. Accumulation of porphyrin, heme, is the problem, okay, with these people, okay? So, large amounts of excreted in urine and feces. So what does this lead to? This is the mythological character, the vampire, and a werewolf, okay? This is where they came from, all right? Back in the day, when people didn't know any better, all it was a genetic disorder, okay? Porphyrias became very interesting because they started affecting the royal family, especially the Queen Mary of Scots. Okay, she had a son that was definitely, they thought he was a vampire or a werewolf, and research has basically shown that he probably had porphyria, had a genetic disorder. Okay, the royal family had lots of genetic disorders. Why?
Inbred.
Inbred. Cousins marrying cousins, okay? And so you ended up having lots of abnormalities, and porphyria was one of these, okay? Princess Charlotte, who was, I believe, maybe King George, one of the King George's daughter, died at birth. And she was actually the one that would probably have inherited the throne, but she died at childbirth, and they actually feel like that it was probably a porphyria attack on her. In other words, her body basically was producing so many porphyrins that it destroyed like her liver and stuff, okay, as she goes. So porphyria has been around for hundreds and hundreds of years, so they have some unique characteristics, okay? So excess porphyrin deposits result in photosensitivity. What does that mean?
Sensitive to light.
Sensitive to light. What do vampires do in the light?
Yeah.
They die, right? So people who have porphyrias, they tend to like the dark, which leads to vampires, right? Abdominal pain, neuropathies, neuropathy is how it's pronounced. Neuropathies, basically any kind of neurological problems, okay, abnormalities, all right? So 2 forms, depending on primary site. There's one that happens in the liver and one that happens in the bone marrow. We're going to talk about the erythropoietic, not the one that happens in the liver, okay? So we're going to look at the erythropoietic ones. There's two of those, okay? All right, this is a good chart that kind of tells what's going on with all of them, the liver ones and the erythropoietic. But the ones that I'm concerned with are the two erythropoietic ones, which is congenital, and then the erythropoietic protoporphyria, EPP. Okay, so those are the two that we see. This one is usually the one that's the worst on. Okay, I want to talk about that in just a minute. Okay. All right, so two types we're going to talk about, CEP and EPP, okay? EPP anemia is usually pretty rare, but CEP usually a hemolytic anemia associated, okay? So these basically some more information, you can kind of look at those. Type 1 and type 3, the porphyrinogens, which is right before it goes in the cytoplasm back into the mitochondria, to be associated with the ferrochelatase and produce that protoporphyrin 9 ring. Okay, so this is where it is. So it never makes it to that part. So you have an excess of like those urobilinogen, the uroporphyrinogens, the coprotoporphyrinogens, and those kind of things are accumulating in the cells. Okay, so those are known as porphyrins. Okay. So that's our problem with this particular condition. These porphyrins become toxic to our cells. Okay. So RBCs contain porphyrins. So what's really unique is red blood cells fluoresce red under UV light. Okay. So they glow in the dark or in the UV light. Okay. Another place that porphyrins are deposited is in their urine, because they're trying to expel those porphyrins, so their urine glows red in the dark. Okay? Not only does it glow red, but it also is red. It is known as port wine urine. Port wine urine. Okay? And I got a picture of that in just a minute. Okay? Another place that porphyrins get deposited is in their teeth. So when you shine a UV light on a person who has porphyria's teeth, they look like they're blood red. So therefore, they've been sucking blood. Right? More vampire. Does that make sense? Okay. All right. So CEP, presence of excessive amounts of type 1 porphyrins. So uroporphyrin and coproporphyrin are the two big ones that are in these. Okay. Defect is the uroporphyrinogen 3 synthase, which is the actual enzyme there. So what happens? Deposited into body tissues, excreted in urine feces, and intense fluorescence with UV light verifies the presence of these. So essentially, if you ever suspect somebody's got porphyria, you don't have to do a test at all. You just put them in a room and put a UV light in their face and their teeth will glow, or their urine will glow. And that's all you need, because nothing else freaking going to do that. Does that make sense? Okay. All right. So urine pink to reddish brown is known as port wine urine. Extreme photosensitivity to sunlight. They actually get these sores on them, on their body, because of this. So you have scarring and mutilation on the face, ears, and hands, which also leads to like werewolf and vampire things. Okay. Teeth stain brown, but then they fluoresce bright red under the light. What's hypertrichosis? You know what hypertrichosis is? Anybody ever seen that term? Increases something. In this case, it's hair production. So they actually grow hair. And what's really weird is a lot of times it's like a fine fur, almost. It's almost like fur on them, like a fine downy hair on them. Real smooth and soft, okay? Splenectomy, you know, splenomegaly, you know what splenomegaly means? Enlarged spleen. Mild to severe hemolytic anemia, the red cells, they only have a lifespan of about 18 days on these people, okay? And then these are pictures, okay? So you can see the scarring that you have. The hypertrichosis, you can see it all over their face. This is what led to the werewolf symptoms. They thought they were werewolves, okay? And then, of course, this is what their teeth look like. And then you put the UV light on them, and they glow red. Okay? Questions about that, guys? Okay?
Common around here?
No, it's a genetic thing, and it's actually, this one is a recessive, especially the CEP. CEP is recessive, the EPP is a dominant gene. So if you're going to have one of them, the EPP would probably be the most common one of these two congenital forms. Now you can have those acquired forms in the hepatic forms, you know, but these are the two that we worry about with erythropoiesis. Anytime you start seeing recessive things pop up, that's usually a sign of inbreeding, and that's what happened in the royal family. So no, it wasn't very common, but it was more common than it ever should have been in those particular families. Okay, and that's usually what you'll see if you start looking at like the family tree, the pedigrees of the royal families. You'll see lots of people being affected by a certain thing, but it's a recessive disorder, but because of the inbreeding, it got passed more than what it would normally. Okay, as you go. Okay, all right, questions about that, guys? So, mild to severe normocytic anemia. So you would have normocytic hypochromic cells, okay? Lots of initio and poiculo, significant polychromatophilia, so lots of retics because they're trying to compensate for the cells. And then those RBCs fluoresce under UV light, okay? Bone marrow, you're still going to see kind of the same thing. You're going to see erythroid hyperplasia. Erythroblasts usually fluoresce also with UV light. Normal serum iron and storage levels, no problem there. Haptoglobin is absent. Why? Why they have no haptoglobin level? Y'all remember? What's haptoglobin do? We just talked about it. Binds free hemoglobin. Remember also when we talked about hemoglobin breakdown in the chapter 6, we said that haptoglobin is usually the first one to disappear because we don't make a lot of it. Remember? And so like that's one level you can do to basically judge how severe the anemia is or the hemolysis is in that patient. So remember, these people only have, their red cells may only last 18 days. So then they're going to bust and release the hemoglobin, and haptoglobin is going to bind to it. So they have a perpetual zero haptoglobin level because they just can't make enough to compensate for detectability. Okay? And then you see increase in the direct and indirect bilirubins as you go. Fecal urobilinogens and all this kind of go with all that. Okay? Prognosis and therapy, survival usually not beyond the 5th decade of life. So usually not in their 50s. You never see a 60s Porphyria person, okay, 60s or 70s. They usually don't make it, okay? Blood transfusion with iron chelators. These are some of the things that they can do. They can try bone marrow transplants in some people, okay? EPP, this is the one that's less severe. You can kind of look at it and read about it. You basically just have excess protoporphyrin 9 because there's a defect in the ferrochelatase. Usually don't see this in the urine, so their urine doesn't glow and they don't have the port wine urine. Okay, so basically they're kind of right the opposites of each other. EPP and CEP are kind of opposites of each other. Okay, I think that's pretty much it, guys. This is a good chart right here, table 1217. This kind of goes back and gives you a good review of all the different anemias that we've talked about. What you can see, what the CBC shows, what iron studies, and then other things that are necessary for learning. Okay? Questions about any of this, guys?